tenodesis, where to fix it, intra-articular in the groove, supra-pec, sub-pec, and how to do it, which technique to use. Now, just before starting with the answering these questions, to do tenotomy versus tenodesis, what are the indications to do tenotomy and what are to do tenodesis? Who do frequently tenotomy for the tendon? So yeah, when you do tenotomy and when you do tenodesis?
I think I will forward the question to Alexander.
Yeah, okay. So, what?
Yes,
So we have
basically old age, young age.
Yeah, a lot of controversy, and it's surgeon decision, maybe, and surgeon's experience. But in general, we fix it in young, active people, and we can cut it in elderly people, especially obese. Because if you do tenotomy, you may have that cramping pain in the arm, maybe Popeye sign, different from 40, maybe more than 30% of cases, but most of them not aware about that. And with tenotomy, you may have loss of flexion and supination power, though not too much, but it may be important for the young active patient. So in general, we do tenodesis for young active and tenotomy for more elderly people. And now, when to do it, we have always we do operative treatment when conservative fails. This is the rule. And these are the indications to do biceps tenotomy versus tenodesis when there is slab lesion, when there is tear on degeneration of the tendon in the joint. And if it's more than 25%, you can you do tenodesis, and if it is less, you can just deprive. In cases of polylesion, most of the time these polylesions are part of rotator cuff disease. And when the groove is diseased, when the tendon has disease in the groove, and we see this a lot, that there is severe tenosynovitis in the groove and sometimes degeneration of the tendon. These are mostly the indications. Now, where to do it? Intra-articular, supra-pec, or sub-pec. We know that sub-pec is the test of time. This is the most commonly used before the era of arthroscopy. And it has good results and preserve the power with much less pain than the other procedures. We have the intra-articular tenodesis. In my practice, I do this when I have slab lesion, especially in older than 30 years, over than 30. And when there is intra-articular degeneration or tear, or when there is polylesion, I do intra-articular. And sub-pec, I do it when the disease more proximal maybe, and when the disease in the poly or in the groove. But when there is severe degeneration of the tendon in the groove, I would prefer sub-pec tenodesis. How you do it, open or arthroscopic, what you have used to do. If you do open, or arthroscopic. If you are arthroscopic surgeon, you can do it arthroscopic. And I don't think after a few months there's any difference between both techniques. To do it soft tissue or bone fixation. Ziad, do you do soft tissue fixation of the biceps? We do it as part in arthroplasty. Maybe in arthroscopy we don't do soft tissue, we do most bony fixation. I used to do sub-pec soft tissue tenodesis, just turn around the lower part of pec major and suture with a stitch. And in my experience, I found that much less painful after the operation, and the functions were good. So this is one of the techniques you can use. It's cheap, quick, and much less pain. Now, this is case one. This patient has, this is a female patient. She has rotator cuff disease and tear, and this is the intra-op finding. And you see here the poly is affected, the posterior part of the poly. And here when doing the debridement of the stumble, the subscap is okay. When you debride here, the base of the rotator cuff, you can see that the poly is affected, the posterior part. So the tendon is subluxable more posteriorly. So what to do in this case? We switch the scope to this sub-pec, the subacromion, and you see it's large. It's not small like it seems in. And if you go in, you will see the bicep there and the poly is affected. Now, what to do in this case? Sam. What you do intra-articular tenodesis, part of the cuff. What? Tenotomy man. Okay. So Ziad, tenotomy versus tenodesis.
Actually, it depends about age.
50.
50?
58.
Yeah,
Female. Thin. Tenodesis. Intra-articular or subpec or suprapec.
Just the top of the knee.
Top of the knee.
The top of
Yeah.
the knee.
Here, what I did, I debride the bed, and after that, test what type of tear, and you see it's L-shaped tear. Okay, it's L-shaped. And now I bought a needle, so if I do suprapec just to keep the length and tension, but then I changed my plan. I decided to do it part of the rotator cuff repair. And here we have, it's very important in placement of the anchor is to be close to the articular, but not penetrating it. Okay, and the trajectory, the direction also should be important. Now, prepare for the anchor. And here again, you have to make sure the direction is good and you don't penetrate the cartilage, okay? And now one trick is to keep it in, and when the anchor is ready, just to remove and put the anchor, so to keep the track for you. And here, you remove, so it will keep the track open and you put the anchor. If you remove it early, you may have the tissue closed. Now, what's portal? I use needles always. Put the needle, see that you can reach your target, okay, and then you make the portal. And you dilate with a scissor. And now, what type of stitch? It's also different. You can have simple, lasso stitch, whatever you want. It should be just grasping the tendon. And here, I use this instrument, direct passing, and take a good height of the tendon. I like lasso loop or multiple lasso. Then take the suture. You can make a loop and then passing that instrument again from that loop and you see it. La force. Exactly, you described this. Okay. And you can polish that and pass it again. And this, what's nice with this technique, that you have one strand of the suture is the post. So when you pull it, you get the tendon near the anchor, and I'll show you that. And here, when you do the second one, you may sometimes have difficulty to reach the suture, so you can use both hands to grasp it. And now you see here, when you pull the post, this one, it gets the tendon toward the anchor. And this is very important at this moment to make your assistant tie the suture. Because when you finish the repair, you will be maybe confused to pull it. If it's the wrong one, you will get the tendon away from the ankle, away from point. And here you cut and the stump, and then you remove that part of the biceps from the and after that, you start you can start repair of the tendon, and here very important where to distribute your sutures. And in this case, I make it a little bit posterior, the first one, because the one used for the biceps, I use it for cuff repair also, and I'll show you now. So, grasp and passing through the tendon. And here, when finished passing the suture, I pass the post here, and then after that, the other strand through the cuff. So they will tie the cuff and suture the biceps syndrome. Okay? And you see that after finishing, when you pull the post, you will get your tissue to the point. And here, after repair, it was very nice after completing the medial repair that the biceps tendon is here. You see, it's close to the ankle. You see? So it's grasped with the rotating cuff. Here, after finishing the repair. Now, this is intra-articular case of intra-articular tenodesis, and as I told you, there is a lot of controversy about which technique. For example, let's take this case. and discuss with our colleagues who will do tenodesis for this. This patient is a middle-aged. I did for him a pancreas repair, and during the operation, I found this. There is a small tear here in the anterior part of the cuff, which was debrided, and there was severe synovitis. And the patient pre-op has instability and anterior pain. Who would do tenodesis?
As we said, Dr. Asad, as we said, when there's a failure of conservative.
No, this is intraop.
This is intraop.
So,
You didn't plan before that.
yeah,
you need to-
intraop.
You'll
So this
find-
is synovitis
Yes,
in the
synovitis.
groove, and this may be cause a residual pain. What I do, if I ask myself to do tenodesis or what I do, because I cannot accept post-operative residual pain. Redo surgery in our country is a problem. So I decided to do tenodesis for him. Sorry. Yes, when you put the needle, you define where your portal, and you should be comfortable with that, and then you make the portal. And after that, you grasp tendon before cut it, because you may lose it. And I use the cuff grasper, and after grasping the tendon, you can cut. And after you cut, you pull it out. And there are different techniques for intra-articular tenodesis. What I use here, that I take the tendon out of the wound, so I widen it, I make web stitches, and I use knotless anchor to fix it. Okay. So here, after repairing the bed, always remove the bony debris, because this can cause synovitis after operation. So remove, smoothen the bed, and then prepare for your anchor. And here, very important to have the proper direction, otherwise it can slide. And after you make it, you can introduce your anchor. This is knotless anchor, which grasp the suture. And here, very important, when you do it, not to have the anchor behind the tendon. Try to have the tendon closer to the groove, and the anchor on the other side. And here, you see, fixation, hammer it, and then fix it. Now, this is a case. Yes.
Just a comment. It's very important when you decide to do a tenodesis. There is you should observe that about the position of the forearm and the elbow. If you do an tenodesis with tensioning of the tendon, it will become more tension.
This is very important.
Very important
that you
technical.
don't have the tendon tight
or
pain,
lax.
or lax, because this will not function. Now this is a case of suprapic. I'll show you some points. When you do it, you have to see the pic major, the upper part of the pic major, to define that, and you define that clearly. Sure, you don't need to go more further, and then you define where is the tendon. And sometimes you may have difficulty to see it, so you can prop it. Use your instrument as a finger. You can palpate, and you see how it's folding under your instrument. And here you prepare for the bed. You define the tendon, here the tendon. Okay, and after that, you can put a needle, make another portal, and put a retractor. And I'll show you here. This switching rod, you can use it as a retractor to hold the biceps away from the groove. And then after that, you make your stitch. And again, you have different types of stitches. And sometimes what I do, I mark it at the groove and then take it out again, move the needle and make good stitch, and you can fix with not interference screw, with knotless anchor. In this case, I used interference screw here. This is important to have when you drill. You don't go to other cortex, because this can cause fracture. Just one cortex, and you do tap, because this is very rigid bone. If you don't do tap, you cannot get to your anchor. It's very important technical tips. And after that, we need a cannula with very large anchor. This is 8, it was 8. And this is used interference screw. What's important, or in my finding with my patient, I don't use this technique more, because my experience, I have my patients have pain. So this is large. When you use 8 millimeter or 7 millimeter, it's large. And in a cortical bone, risk of fracture, and the second that they have pain. So I'm getting less, this is answer of while, less and less using this technique. The last time I did just normal 4.75 knotless anchor to fix it, because they're very much smaller, 4 millimeter to 9. There's a difference. Okay, and this by conclusion, long biceps tendon problem can be surgical treatment once conservative fails. Many techniques are available, but there is no consensus about the best one. And do what's best for your hand. Okay, thank you.